when patients require frequent phlebotomies and taking blood from them, ultimately this leads to iron deficiency. Iron is the building block for hemoglobin, which is a main component of our red blood cells. Patients who have polycythemia vera are constantly making red blood cells, therefore they're using up their iron stores. So they're typically iron deficient when they present with their diagnosis. Then we take blood from them over time serially, which leads to further progression of this iron deficiency. And it's really a problem that we're almost trying to create, because we don't want the body to be able to make the red blood cells that it's trying to make. And so we almost induce a severe iron deficiency, which then leads to its own symptoms. And so we kind of get into this catch-22 where the treatment that we're providing in order to protect patients from thrombosis is causing another problem that we don't really feel like we really want to solve, because then it leads back to our original problem of having too high of a hematocrit. And so hepcidin is a protein that our body makes that is a master negative regulator of iron. And so theoretically, the idea was that if we can provide a hepcidin mimetic, then we can kind of do a couple of things. One, we can induce an anemia, an iron-restricted anemia, while at the same time allowing the iron stores to replenish. And so we'd be able to kind of keep the blood counts at a safe level while reversing the iron deficiency and improving those types of symptoms. So the study was designed to provide this hepcidin mimetic, or PTG-300. And in the first portion of the study, the goal is to provide this medication at increasing doses in order to achieve a hematocrit reduction into what we consider to be our goal zone, what we're trying to keep things at. And so we enrolled patients that were requiring frequent phlebotomies, regardless of other therapies they were for polycythemia vera. So patients could be receiving hydroxyurea, ruxolitinib, interferon, or no other medication, just phlebotomies alone, but they had to be requiring phlebotomies. And then we give them PTG-300 weekly, and every month or so, we would increase the dose in order to kind of get the hematocrit into what we consider our target zone. And then for the next portion of the study, after dose escalation, we kind of titrate the dose to achieve what is individually the right dose for that patient. And what we saw is, remarkably, PTG-300 was able to basically eliminate the need for phlebotomy in these patients that were requiring regular phlebotomies prior to going on the study. And that was certainly what we were hoping to do. And in addition to that, what we were able to see is that it actually normalized ferritin levels, which is the main measure of iron storage. And so it was able to do the two things that we were hoping that it would do, which is reduce the need for phlebotomies and normalize iron stores. And then associated with that, which really what it comes down to is this clinically beneficial for patients? You know, is this replenishing of iron stores actually helping patients feel better? And we did see some signals of that as well, where patients' symptom scores were improving over time. So the study is still ongoing and needs to fully accrue. We're about halfway through, and we need to fully accrue the study and certainly watch these patients more for the duration of the study. But I think that what we're seeing is proof of concept that this drug does what we were hoping that it would do. And the next step is to see how this can make sense and how to bring this, make this clinically available to patients. Right now, the way I see this drug is we have a lot of patients that require a lot of phlebotomies, and phlebotomies is a really archaic way of treating patients to perform bloodletting, essentially. And this is an agent that allows this to be done in a much more rational way, and it does that without creating a new problem that we then have to deal with. And so we just have to figure out a way to make the case for this being a realistic agent and being able to get it into our patients' hands so we can provide better care.